We're studying blood, part 6, and it's page 644, and we're in this table right here in the 17th chapter, table 17.2, where we've collected the white blood cells and some details about them. We're looking now at the eosinophil. We just did the neutrophil, and we noticed that it has the capability of a respiratory burst. Here we have another granulocyte, this one less in evidence most of the time. When do we see this most often? This particular eosinophil type is one that has granules of the red color persuasion, and the granules actually contain special tools for piercing and killing parasitic worms. So that's what its expertise is. It has a very complex role. In addition to that, it might be present during allergies in the United States and in wherever you have a high level of hygiene in the homes and in public settings. You don't actually get to see parasitic worms very often, somewhat rare event, and so you might not see this expansion in the blood, but there could be an allergic reaction which is sustained over a long period of time, including asthma, which could be also a part of the hypersensitivity part 1 situation, including pollens and danders and things. So this particular cell can be present more often and respond to things. So then we come to this next cell here, which is the basophil or mast cell. We call it a mast cell, M-A-S-T. It often is the type of cell that will have an immunoglobulin E seated with its tail into the cell, and its active sites here, its variable sites, sticking out, waiting for an allergen to come in and bind. Once that binding takes place, then we have the release of histamine. And so that's the main job here, is the release of histamine. There's other mediators, all of which stimulate the inflammatory response. And so we think of redness and heat, swelling, and pain associated with inflammation. So that's what histamine is doing for a living. There are some molecules that can cause transudation of fluid and sort of extra swelling going on. There's also anticoagulants present in that release along with the histamine. Okay, and then after we've dealt with that, then we deal with these guys right here, and we have a special handout for that I'll go over momentarily. First, I'll talk about the platelets. Okay, so platelets are actually described here. Here we have a pluripotent stem cell, which is giving rise to a megakaryocyte. So the megakaryocyte actually never leaves the bone marrow, but portions of it pinch off. And here you can see that those portions are represented here as platelets. Sometimes they're referred to as thrombocytes. So that's an important detail. Take a look here at what the possibilities are for these platelets or thrombocytes. And here you can see in the bloodstream we have a small vessel, could possibly be a capillary or just a small arterial or venule, and we have some sort of injury to the wall. We have the presence of blood here, and what we'll notice here in step 2 is that platelet plug is going to form. You see the very beginning of it. They're beginning to attach themselves to the collagen associated with the open wall structure. So the collagen becomes revealed in that. That's sort of like the scaffolding, as it were. Eventually, enough of these platelets build up, and we occupy a space right there, and we close off that space so that there's no further leakage. And if there's continuous blood flow, then we just get this little small area that's associated with that. We don't get some sort of major buildup. It's possible then to have like sort of a scab-like device that's inside there. It's something that's common that you would find on your skin. If you were to abrade or cut your skin, there's going to be a scab that forms. Okay, so that's the event of what we call hemostasis, or the formation of a clot. And they list them here, the various stages. The stage 1 is vascular spasm, followed by the platelet plug formation. Okay, so there is a reaction and a response to that reaction with the platelet plug. And ultimately, we'll get coagulation as a result of the plug, but we get some special extra features that get sort of placed in the way of that, that I'll get to in just a moment. But first we're going to do this quick little cascade here in which we have the, it's called the Hagemann Factor, in which we activate a whole chain of events. We don't want blood to become coagulated on a regular basis, so we actually have to turn many keys and many locks. So the intrinsic pathway here is what we just saw, the platelets clinging to the walls of an open wound that usually has some collagen associated to it, and that activates, that's part of the activation of 12. Here, factor number 12 becomes activated. We have a little sub-A right there. These are all molecules that you're seeing here that are produced by the liver. Okay, so they're just out there in their inactive form. 12 becomes active, that activates 11. 11 becomes active. There are some other factors that come in that need to be activated, along with some calcium. Calcium plays a role here. It seems to play a role in many things. Okay, so then number 9 gets activated, and it forms this active format. It then gets associated with what's called PF3, which is released by the platelets itself. So then that combines with 8. So 8 becomes activated, and you'll notice that all of these come together as a single complex. So 9, 8 is complexed with PF3. And by the way, 8 is missing in certain individuals genetically through an X-linked chromosome, and this is a problem for people, mostly males, in the royal family of Europe. Okay, so the factor number 8, there's many people other than those specific individuals who might have hemophilia, and so they'll be needing to get factor 8 from some doctor's prescription. 8 can be combined then as a complete complex, and we're going to activate number 10. 10 comes over and again creates a new complex. After it activates number 5 to become active, after more calcium comes in, more PF3 comes in, we finally have the prothrombin factor or activator. Okay, so prothrombin right here is an inactive form that's dissolved in the blood. We now get thrombin. So then thrombin plays some roles. You can see that it's a coenzyme in more than one pathway. The first pathway is to take fibrinogen, which are little tiny, sort of like beads in a way. They're like little globular proteins, and we put them together. This is the way you string beads together. You can string these together and you get these long fibers. Now that you have the long fibers, the next thing you have to do is you have to connect the fibers into a fabric or a mesh. And so more calcium comes along, more thrombin comes along. We activate 13, and 13 facilitates this fabric-like structure with a warp and a weave combination. And over here we're seeing how the fibrinogen has actually become long fibrin particles, and then they've created cross links and meshed together.